if anyone can participate. Faisal, تشوف أحد raising their hand ولا I can pick up randomly.
No one yet.
خلاص. في دكتورة ديما جومر. She can unmute.
السلام عليكم.
هلا عليكم السلام. كيف حالك دكتورة؟
الله يسلمك. الحمد لله. كيف حالك؟
الله يرضى عليك. الحمد لله. طيب this patient احنا this bulk or the second part is much shorter compared to the first one. It's going to be faster اليوم. فممكن ناخذ راحتنا بالدiscussion. This patient she's complaining of pain, progressive pain and in the right eye and asymmetry. How do you like to approach this patient?
Okay, so I'll start by describing. I can see unilateral right eye proptosis with inferior displacement or hypoglobus. Also, there is signs of inflammation. I can see injection, conjunctival injection. Not sure if there is any element of chemosis. I would examine with the slit lamp.
Okay, so let's, in terms of history taking, what will you ask?
Okay, I'll ask about the onset of the symptoms, the progression.
So it's been there for about 6 months, progressive and painful.
Okay. I would ask about a history of a previous similar presentation.
No, it's been there for the past 6 months.
Okay. Any involvement of the other eye during this course?
No.
Okay. So I'll start asking about some ocular symptoms such as diplopia, pain.
Okay. Good. So visual complaint. And what about systemic-wise? Would you ask about something systemically?
Yes, I'll ask about, first of all, signs of thyroid eye disease, such as any weight loss, weight gain, constipation, diarrhea.
Okay, so constitutional symptoms. Okay, so what about the examination? You would like to highlight what the exam?
On examination, I'll start by taking the visual acuity and taking the IOP, visual field, color, vision, and I'll examine the optic disc. Following this, I would want to first start by palpation. Then I would also check the extraocular movement, any limitation.
So there's no limitation. However, there is significant pain and injection in this area. Okay, then what will you do after that, after examination?
Okay,
of course, you need to check exophthalmometer and the optic nerve function, motility. So after that, what will you do?
I'll proceed with imaging. I would like to have a CT.
Okay. CT scan. Okay, so this is the CT scan. Can you describe?
Okay, this is CT scan, coronal cut, soft tissue window that shows a right orbital, superior temporal, heterogeneous lesion that is around maybe 1/3 of the globe, ill-defined and displacing the globe nasally. There is also an area of associated lateral orbital bone destruction.
Excellent. This is the most important finding. Okay, so if you want to characterize more, you can request MRI. Sometimes it's good to have to check bone window because sometimes subtle bone destruction is not clear in soft tissue. So what's the differential? So she's a middle-aged lady with 6 months progressive pain in this area. So what's differential diagnosis?
Okay, I would think about my top differential would be a lacrimal gland malignant lesion, possibly adenoid cystoid carcinoma.
Okay.
I would think of, but now I'll start to differentiate, to give some other differentials based on the bone destruction that is having. So maybe this can be some sort of metastasis,
Okay.
although not typical for the history, but
Okay, sure. But what else? Other differential? Yeah, aggressive type of lymphoma.
Yeah.
Okay. Sarcomas. Okay, so excellent. Most likely diagnosis is, what do you think?
Adenoid cystic carcinoma.
Okay, excellent. Just don't mute your mic. Okay, so excellent. It's adenoid cystic carcinoma. So typically, it's if you check the literature, there is variation of the age, but the average or the range is second to fourth decade, and pain is the most important predominant symptom. It's very important as a buzzword. Remember last time I was stressing buzzword in ocular, on oral exams. So it's the main infiltration of this type of neoplasm is pre-neural invasion, as well as bone infiltration. So duration is always almost always less than 1 year, and it's not. Remember the last time in the first part of my talk, I said that you need to know the phenotype of each disease. So it's quite different than polymorphic adenoma. So the 5 subtypes, as you can see here, there are 5 subtypes. Do you know what's the worst subtype? The worst subtype of all these in terms of prognosis? Oh, I wrote it down here. So yeah, it's a basiloid. Okay. So this depends on the predominant pattern and pathology. The pathologist will tell you that the predominant part is cerebroform or sclerosing, basiloid, and etc. Okay, so the treatment, there's a lot of controversy in this when it comes to adenoid cystic carcinoma. So generally speaking, if it's less than T3, meaning larger than 4 centimeter, globe preserving surgery followed by or preceded by radiotherapy is advised. However, worse than that, this is the controversy, that they say that some clinicians advocate orbital exentration followed by radiotherapy, and still there is no evidence of any scientific evidence between the radical surgery or the less invasive one. So generally, the treatment will be incisional biopsy and debulking of any evidence of any tumor, and to comment if there is any invasion of the bone or the preosteum. And an oncology consultation is very important to do a systemic workup. As we said, the metastasis is mainly pre-neural. However, it can be lymphatic, hematogenous, mainly to brain and lungs. There are different very nice reviews about this topic, like this one, and also this one. And this Peter Ismaili is very active in this when it comes to adenoid cystic carcinoma. So if you look it up, you're gonna see a lot of good studies about it. Like this one, 7 patients. Of course, this is a rare disease, so usually you will not see a lot of patients recruited. So 7 patients underwent very radical surgery, and 5 of them, they succumbed to the disease 12 to 32 months after surgery. However, 2 patients were still alive without evidence of disease. Of course, the follow-up is very short, so still it's not a very accurate study, but it's an observational one. So, Dr. Hala, if you can comment on this, since you are very experienced in the oculoplastic field, what do you think about sebaceous cell carcinoma, adenocystic carcinoma, and how to approach the surgery.
سامعيني الحين؟
أيوة.
Yes, I didn't see a lot of cases, يعني, as you would imagine. But I was listening to a lecture today about tackling the orbital tumor, and it was including the adenocystic carcinoma. He's a doctor from India, Hyderabad, and he was talking about the that the prognosis, since it's similar, he would include a multi-system involvement. Like they send the patient to have chemotherapy to shrink the tumor a little bit, then excise it immediately after. Then the patient will receive again chemo and radiotherapy. So this multidisciplinary approach would give a better outcome than even excenteration. Because once you shrink the tumor with chemotherapy, you're also killing any distant particles if it had started to metastasize. So, and then when you remove it, you are it's a little bit shrunken, more controllable. However, if and he's talking about the type which is more not very localized. However, if it's more localized, he would still go for a complete excision to start with. And he was talking about he doesn't remove any of the bone. He would just remove the periosteum, and then set for chemotherapy afterward. He wouldn't just stick to just removal.
I see. It's a very tough neoplasm to treat because there is no consensus. For example, Moorfields, they have a study of where they do intra-arterial chemotherapy. However, it has a lot of drawbacks because while doing the surgery, you may damage the lacrimal artery. So you're not sure that the chemotherapy will go to the tumor. So still, even if they have favorable result, it's not that accurate. I think
he was commenting about this intra-arterial, and he said the problem with intra-arterial not killing the systemic metastasis. So he would really stick to a systemic chemotherapy rather than intra-arterial, because you will be sure that all the cells have been killed. Not after you remove it, you would have a metastasis.
What I gathered from the literature, that so far the consensus is this for the resident: if the disease is limited to the orbit without bone destruction or sinus involvement, meaning T3 or less, so removal of the whole tumor macroscopically with post-op radiotherapy is the with systemic workup is the best management to do. However, if there is a residual tumor post-operatively or there is a recurrence, this is another issue. Should you do exentration or not? Because the question is how exentration would help in terms of survival. Still, there is a debate. But it's not an easy tumor to deal with. Okay, so شكرا دكتورة علاء على الكومنت. Okay, so let's see. Faisal, إذا في أحد, you can choose randomly. Anyone? Faisal?
معاك يا دكتور.
Okay. Just choose randomly أي أحد من الزملاء.
في نواف المقبل.
نواف جاوب آخر مرة. لا, let's choose another one. حمود العتيبي موجود؟ ما هو موجود. هاجر البريس موجودة؟ What about سارة العويضي؟ معقولة ما في أحد من... Okay, I'm gonna choose randomly. Okay, عبد الله خان.
السلام عليكم.
هلا. عليكم السلام. هلا. كيف حالك عبد الله؟
كيف حالك دكتور؟ كيف صحتك؟
الله يسلمك. This patient came with asymmetry and droopy lid in the left eye. So how can you approach this patient?
So first of all, we have to start with history. We'll ask the patient when she noticed the droopy of the eyelid.
Yeah, so for long time, more than 1 year.
So it's more than 1 year. Does it change during the day or not? Is there any history of trauma to the eye? Any history of surgeries before? Any medical conditions like thyroid and body thyroid disease? Then after that, we will ask the patient about any change in vision, any diplopia.
Okay. What about examination?
The examination will start with the visual acuity, and then after that, looking for the patient, look for any features that can systemic feature. Then going to the eye examination, looking for the ptosis, measuring the ptosis.
Okay, so tell me about the parameters that you will check.
So we can measure the MRD1, the elevator function. Also the palpebral fissure height.
Okay.
Other than that, the extraocular motility.
Okay.
Again, in ptosis, we can also check the lid crease. Extraocular motility and ABD.
What else? غير ال APD, we'll check the pupil if there is nisocoria, صح?
Yes.
Okay. Still, there are a lot of parameters in ptosis that you didn't mention, but it's okay. You can revise them later. Okay, so the elevator function is normal, meaning that it's more than 15. And the lid crease, you can see it's not high, very symmetrical.
Yeah.
The Hertog's ophthalmometer is normal and symmetrical. So what do you think? Why would the patient have ptosis, even though the elevator function and the lid crease is normal? Upon down gaze, there is no lid lag, so there is no signs of congenital ptosis. And the history is not suggestive. So why would the patient have ptosis?
It could be for as aging process. We can see the patient is old.
No. So there's no neurological explanation, meaning that there is no no nerve palsy, no signs of Horner syndrome. There's no signs of congenital ptosis, no signs of involutional or disinsertion of the elevator muscle. Yet the patient has ptosis.
Yes, so it could be mechanical or...
Okay, excellent. Mechanical. So what are the things that you can do first in examination to rule out mechanical? So you have Hertog's ophthalmometer, okay?
Yes.
And you always check if there is any displacement or dystopia. Okay, what else? How can you check for any mass clinically?
Palpation.
Okay, what else?
Over the head. And then also, of course, an inspection, like especially that the lacrimal gland, we have to look for it.
Okay, so how can you look for the lacrimal gland clinically?
By version of the lid, and also looking at
so you averted the lid, and this is what you saw.
So here we can see there is like a cyst in the lacrimal gland. It looks like it contains fluid in nature, so we have to assess this cyst by palpation. Is it tender? Is there any signs of...
So it's painless, and this fluid can containing, as you mentioned. So what's the most likely diagnosis?
So the lacrimal gland cyst dacryops.
Dacryops. Okay, excellent. And what's the treatment?
The treatment would be dependent on the symptoms. Is it or not? If it's like mild, we can observe it. If it's like large, then we can go with the excision.
Okay, so if it's not bothering the patient, you can observe. However, if it's causing ptosis or bothering the patient, you can do the surgery. Okay. So what if you will do the surgery? You will consent the patient about which complication that may happen.
Complication we can think about.
So one main complication. You have here
the lacrimal gland itself. It can affect the patient might have dryness.
So yeah, injury to the ductules can cause dryness. Okay, excellent. So this is lacrimal gland dacryops, and as we mentioned, if it's small, just observe. If large, there are reports that they do simple marsupialization, other they do excision. Dr. Hala, in your experience, which modality you prefer?
As in oculoplasty, we open and see, and if we can remove it as a whole, it will be better. But sometimes when you are worried about the lacrimal ducts, you would probably remove as much as you can, which will account for marsupialization, which means you left some place in it. And one of the tricks which you can help is putting concentrated fluorescent, which will show the ductule very nicely if there is some secretion. So you would try as much as you can to avoid it, because usually the location is very, very near to the
yes, I do it myself. It's like Seidel test, dilute. And I noticed that when I do marsupialization, the first 2 weeks, they have a lot of tearing until this fistula closed by itself. I just noticed that.
And the edema, even if you do full excision, they might notice because of the edema in the place. So it's at least few days, the first few days.
I see. تمام. طيب. Thank you, Dr. Hannah. طيب, let's see. Gonna open again. Okay. Okay, Zubair. Can unmute Zubair.
Hello.
زبير ما اسمعك ترى.
الو
هلا كيف حالك؟
صوتي واضح؟
اي بس لو تعلي صوتك شوي.
اي الو السلام عليكم.
وعليكم السلام. هلا حياك الله.
الله يحييك.
طيب, so this child came to the clinic with his parents and they noticed progressive droopy lid and swelling. So if you can describe briefly what you see and the most likely diagnosis and what will you look for?
Okay. So this is an external photo showing both eyes. In the left eye, I can see left upper lid swelling with erythema and ptosis, mechanical ptosis.
Okay.
Yeah, that's mainly what I can see. The right eye seems normal.
Okay. طيب, what do you think most likely diagnosis?
Most likely diagnosis. I have to ask about onset. Is it acute or chronic? I have to ask.
Well, it's progressive. This swelling is progressive.
Since when?
It started at 3 years of age. He's now 8 years old.
Oh, okay. So it's a chronic.
So you can see the configuration.
Yeah,
there's a famous. Yeah, exactly. So most likely.
It's plexiform, yeah, neurofibroma.
Okay. So what will you look for من ناحية الساينز؟
Yeah, I have to examine for other signs of neurofibromatosis such as capillary spots.
كافي أوليت شكلك ودك القهوة. Okay.
شو اسمه neurofibromas. I have to examine the iris for niche nodules.
Okay.
Axillary freckling.
Excellent.
What else?
So, and if you do imaging, what else?
Yes,
you're mentioning the criteria nicely. So,
it's also optic nerves, glioma, sphenoid wing
dysplasia.
Yeah.
So, for clinical exam, it's good to see if there is any pulsatile proptosis. Okay.
Yes.
Okay, and family history is very important.
Yes.
So, regarding Lish nodule, let's see. It's if you are you expecting it to see Lish nodule in a 3 years old child or a 10 years old child?
In a
What's
10
the
years
most
old?
likely?
But I'm not sure.
Or 3 years old?
10 years old.
I'm trying just to highlight that Lish nodules is age dependent. Okay, so you expect to see it in 6 years old and more. There are different incidents, but it's very important to know that it's age dependent. Okay. Of course, very important. This I'm gonna send Faisal some the complete management. Okay, and he will send you, inshallah, management and how to approach, because this is it doesn't come a lot in oculoplastic station. It's more of a pediatric station. So okay, shukran, Zubair. So this is the diagnostic criteria, type 1 and type 2. Okay. So I'm not gonna stress more or explain about optic nerve sheath meningioma or glioma because it's not that high yield. And it doesn't come a lot in the exam. Okay, so before going to the slide, let me just choose randomly. I'm not gonna choose fellows. Okay, دكتورة سارة العويضي. دكتورة سارة.
هلا، السلام عليكم دكتور.
هلا عليكم السلام، حياك الله. طيب, this patient came with this swelling, and how would you approach?
Okay, I'll start. When did this start? When did he start noticing this swelling?
Since birth.
Since how old is the patient?
35.
Okay, so the same size?
Does it? He was told that it became a little bit more large when he was a teenager, but the onset since birth.
Okay. Does it increase with any, for example, Valsalva maneuver or flu, or does it change throughout the day? It's the same since he started noticing it?
Yes.
Okay. Was it painful?
لا, painless.
طيب. Any systemic diseases?
Like what?
Malignancy?
لا.
Hypertension?
No.
طيب. The other eye, it's only one eye.
It's only one eye, and since birth, he's been having this mass.
And his vision is...
Yes. So before asking you about the most probable diagnosis, when you examine the patient in slit lamp, what's the things that you want to look for? I mean, what will you look for when you examine the slit lamp?
Okay, so now externally, I would describe it as a salmon patch nodule with
Maybe the picture is not clear. If you're saying salmon patch, that means you're thinking about lymphoproliferative disorder. So this is since birth, okay? Lymphoproliferative will not be congenital. This is a congenital mass.
Okay.
Okay. Maybe the picture is not clear, but I'm stressing, I'm helping you that it's congenital.
Okay.
Okay. So what will you look for the exam?
طيب I'm not sure صراحة يعني
So you have this mass congenital and it's in
some sort of dermoid or
okay, what specifically? It's a lipodermoid. Okay. So
I would look for other signs of anterior segment dysgenesis, or if the lids are involved, if the patient have systemic features of any signs associated with lipodermoids. Otherwise, I will check clinically if it is firm or cystic. I will check for transillumination. I will check if
okay.
Yeah.
طيب. So another patient came with this.
Okay, so this is more
this
of
is 6 years old, and he noticed this the past year. Painless.
Okay.
So what's the most probable? Most probable diagnosis.
Fat prolapse.
Fat prolapse. So okay, excellent. So lipodermoid, what's the? It's associated with which disease or condition?
Lipodermoids. Dermoids, or the corneal dermoids, are more with the golden hair, but also lipodermoids.
So excellent, yeah, with a golden hair syndrome. So how can you differentiate between orbital fat prolapse and lipodermoid? Okay, so let's go back to the picture. How can you differentiate between them?
The color to start with.
Okay. What else? Of course, my question, because you can answer the question by applying or by examining the patient under slit lamp. So, okay, color, other than that.
Color and age and history. The prolapse will not be congenital or any since birth.
Okay, but when it comes to exam, what are the signs? So color. Okay,
mobility, maybe. The
so
fat.
which one is mobile?
The fat prolapse.
Yes, so it's mobile, reducible, the fat. However, the lipodermoid will not be.
Yeah, should be.
Okay. What else?
Could be bilateral more than unilateral, the fat prolapse.
Yeah, maybe. Okay, what about the conjunctiva? Which one do you think is more attached to the
dermoid?
The dermoid. So conjunctival adhesion. Okay.
It's more less mobile. You can move it till.
Okay, and you can see the concavity, and this is a little bit convex. Of course, here, elderly patient, you can add the differential of or the description of salmon patch.
Okay.
Okay, how would you manage lipodermoid?
We can observe it if it is causing, if it is disturbing the patient cosmetically, or if it is inducing dryness, or if it's near the cornea inducing Dillon. We can.
This is the Dillon effect is more of a limb. Let's concentrate on this one.
Okay, so mainly cosmetically.
Okay. So if the patient elected to undergo the surgery, you will consent the patient for what? For possible complications?
Muscle injury.
So what structures you have here that may be damaged?
Okay, so lacrimal gland, more importantly.
So dryness.
Okay. Lateral rectus.
What else? So diplopia or misalignment can happen.
What else?
Okay, excellent. So it's very difficult to remove it completely. It depends on the mass. Okay, so as you mentioned, conj, scleral adhesion, paler, firm, but this is a very important distinction. Lipodermoid is a choriostoma, so you may find fine hairs and some keratinization, and it's not reducible compared to fatty prolapse. Management, if you can observe, honestly, because resection, you need to be very meticulous in the surgery in order not to injure. I remember seeing a patient who had diplopia and restriction of adduction because there was a lot of adhesions in the lateral rectus. So you need to be very careful and consent the patient and discuss with the patient about these complications. Dr. Ala, can you comment on lipodermoid? I would love to hear from you.
Yes, I can add about the complication. You can run into ptosis, you can run into dryness if you approach the lacrimal ductils. Also, I tell the patient, don't expect me to remove it as a whole. I will remove part of it. I usually advise the patient to remove part of it. I don't say observe unless it's very small, because once they come, they want something. And I see more people coming being a female rather than a male, because they're more concerned about their look. So I would remove just I will tell them I will just remove as much as I can from the palpebral fissure. I will not remove it as a whole. There will be a remnant. I will I will not pull. I will just maybe just get a little bit of pressure on the globe, and whatever comes out for me. Sometimes you get, it's not like the dermoid which you have oozing for the resident. It's not like something will become oozing like what happens in the dermoid when it ruptures. It's actually tissue, and you can just remove as much as you can in that area. Just don't extend beyond, don't dissect. Just whatever you have there with a little bit pressure comes up a little bit, remove it, and just close everything. So the patient would know that you will not go extensive.
And they're never satisfied. I noticed this.
They're not satisfied, but once you tell them I will not remove it as a whole, they can either take it or leave it and go to someone else, because that's would be our offer for them.
Okay, I see. شكرا دكتورة. طيب. I'm gonna need first year resident. I saw Abdullah Bilali. Abdullah. Abdullah Bilali, اسمعني? If you can unmute. Okay. دكتورة ابتهاج.
الو السلام عليكم.
هلا دكتورة ابتهاج.
ايوه هلا.
هلا حياك الله. طيب, this patient or this child came with the parents are saying that there is a progressive asymmetry in the right eye for the past 3 weeks with associated on and off pain. So
okay, I'll start with the description. I'm presenting an excellent photo of both eyes showing proptosis of the right eye with fullness of the superior temporal area.
Okay.
And hypoglobus, yes.
Okay, so what's the differential diagnosis? The child is 7 years old.
Okay, if it was painless, the most important differential diagnosis will be in children optic nerve glioma, especially if it was axial proptosis.
But Dr. 3 weeks history.
Is there any associated fever, respiratory infection?
No, as you can see clinically, there is no, the cardinal signs. There is no erythema, tenderness. So this is a 3 weeks history of progressive displacement or dystopia and proptosis. So what's the list of differential you can think about?
Okay, it could be vascular lesion, lymphatic or varix. It could be also related to the lacrimal gland, tumors, or malignancies.
Okay, let's start one by one. So the most likely, starting by the most likely differential of diagnosis. So number 1, 2, 3, 4, instead of giving categories. So number 1, again, 3 weeks, progressive displacement and proptosis.
Okay, my first differential will be to rule out malignancies, rhabdomyosarcoma.
Okay, this is number 1. Okay, what else?
It could be also vascular lesion.
Okay, other than that. So other neoplasm.
Could be dacroadenitis.
You can see the eye is white and there's no signs of inflammation.
It could be.
What other neoplasm that you can add? Neoplasm, yeah.
It could be neoplasm related to the lacrimal gland, polymorphic adenoma, and lymphoproliferative.
You attended the first part?
Yes.
The phenotype is not the lacrimal gland neoplasm or epithelial neoplasm does not fit the age nor the presentation. So other neoplasm in a child. So you have a child and you want to think about neoplasm. So you said correctly rhabdomyosarcoma. What other neoplasm that you should think about?
I'm not sure.
Okay, so what will you request for the patient? Or
I will order for
next step? Okay, so this is MRI. Okay, so can you describe?
Okay, I'm presented with an MRI axial cut T1 image showing a mass infiltrating the medial aspect of the right orbit. It is molding around the orbit.
Okay, and you can see it's intracornal and extending to the medial aspect. Okay, so what's the most likely? Again, you need to get the differential right. So you have a 7 years old, progressive displacement and proptosis. So what are the differential? Rhabdomyosarcoma, you mentioned it. Other differential?
It could be sarcoma or lymphoproliferative.
What type of sarcoma? It's very rare, but what type of sarcoma?
I think there's something called colorama, I'm not sure.
And it's associated with what? Colorama?
Leukemia.
Which type of leukemia?
I think AML.
Okay, but it's unlikely because it's usually AML precedes. So usually the patient will be known to have leukemia. Okay, so instead of going mentioning something very rare like colorama, you can say leukemia. So leukemic infiltrates. ALL is more common than AML. Okay, so rhabdomyosarcoma, leukemia, high grade or malignant lymphoma. Okay, metastasis. Okay, so what's the most likely diagnosis?
According to the CT scan, it will be the most likely diagnosis lymphoproliferative lesion because it mold around the orbit.
Maybe I apologize for the bad image. Like from the history, you have a 3 rapidly progressive proptosis with and 7 years old child. So you would think rhabdomyosarcoma.
Yes.
Okay. So what's the treatment? So how would you diagnose this?
I will diagnose by performing an orbital biopsy to confirm the diagnosis of rhabdomyosarcoma and to determine the type of rhabdomyosarcoma and the prognosis.
Okay. So what types do you know about?
The most common type is embryonal. The one with the bad prognosis is the alveolar. We have also the polymorphic and the botryoid type.
Okay, thank you, Doctora. So rhabdomyosarcoma, as you all know, most common malignant orbital tumor, soft tissue tumor in children. The average age is 8 years. It's very important to correlate the age. So CT scan usually shows well circumscribed mass, MRI as well. And usually it's, as you saw, it's sometimes it's homogeneous, sometimes it's heterogeneous. However, the phenotype usually is very distinctive. Pathology, as you mentioned, embryonal, botryoid, alveolar, polymorphic. So to memorize it, alveolar is aggressive. So it's the worst prognosis, so aggressive. Okay, the management, you do incision biopsy, surgical debulking without causing any morbidity, and prompt referral to oncologist for chemotherapy or radiotherapy. I advise you to read this study, the intergroup rhabdomyosarcoma study group, and so you would know the different treatment modalities and the correlation between the subtype of pathology and the prognosis. Okay. So as I mentioned, the differential always in a child, rhabdomyosarcoma, leukemia, lymphoma, although less common than leukemia, or metastasis. Okay. Dr. Brahim Mansour, we did the case together, similar history, but it came out as Burkitt lymphoma. And another patient we did, Dr. Abdurrahman Khan, was leukemia. So it's not uncommon. Okay, so let's choose another. Okay, thank you, Dr. Abtihaj. طيب ياسر بن ثابت. although آخر مرة سألته بس I don't recognize a lot of names صراحة. Okay, ياسر.
أيوة دكتور، السلام عليكم.
وعليكم السلام. طيب هذه child 3 years old child and the parents they mentioned that there is some discoloration and asymmetry between two eyes for the past 2 months.
So the start with the history, as you mentioned, Doctor, it's the parent noticed a discoloration mainly in the right eye or the both eye.
What do you think? What do you see?
I see mainly in the right eye.
Okay. What do you see?
I see a discolorations of the right upper lid, with the also ptosis of the right lid as well. I need to rule out also if there is a proptosis in this patient to have a warm view or measure by exophthalmometer.
So she's 3 years old.
Yes.
But clinically there is proptosis. It's very useful to see it from the inferior part, or let the patient look up.
Yes, warm view.
So there is proptosis and it's progressive for the past 2 months. What's the next step?
So next step, I will order imaging, CT, to rule out tumors. So this is a T1 weighted axial cut MRI, showing an infiltrative lesions in the right orbit, intraconal and extraconal, with the extension intracranially. And also there is another lesions in the brain. It's look like mainly in the parieto-occipital lesions.
Okay.
So I have to rule out a neuroblastoma in this case. Could be.
Okay. Why did you say neuroblastoma?
Because of mainly the point from the history discolorations, the natures, it's infiltrative lesions involving with intracranial extensions, and as well the age of it's 3 years.
Okay. Excellent. As always, mashallah, Yasser. Excellent. طيب, so it's neuroblastoma. So it's the most common metastatic orbit neoplasm in the orbit in children. And as you all know, it's located in the adrenal medulla, most commonly, or the sympathetic chain. And usually the symptom rapidly progressive proptosis with periorbital chemosis over several weeks. It's about 50% it's bilateral, and the principal treatment is chemo plus minus radio. So I meant to bring a not clear photo. لأنه usually in the exam they don't bring a clear one like this, but the typical presentation is like this one. You can see a chemosis and subconscious hemorrhage, and when you do a systemic workup, you see the primary tumor. It's very important when you see a child, a young, very young child, let's say 2 or 3 years, you think of neuroblastoma. Again, mostly the differential is the one I mentioned before. It's another picture. Again, typical, sometimes it's unilateral. So I hope it's clear for you. Okay. So let's see. We'll go choose. Okay. Faisal, if you can keep up with the chat, because I cannot. I'm going to look up the participant. If they have any question, Faisal, will chat. You can. طيب. Okay. إبراهيم المنصور. عفوا معلش إبراهيم. خالد الموسى موجود؟ فيصل موجود خالد الموسى؟
ماني لاقي اسمه. اتوقع انه مو موجود.
الجوينت بروجرام الحضور اليوم ما هو زي آخر مرة. طيب إبراهيم المنصور.
I have a comment about the leukemia and neuroblastoma.
Yes.
I always tell the resident, sometimes the students when we are teaching them, that it takes very little effort rather than waiting for something like a CT scan or so on. Like the leukemia, you can see it in CBC. The neuroblastoma, you can just palpate the abdomen if you are not sure. So these things are simple things which doesn't take time, especially the palpation. Even if you are in an ophthalmology room, you can easily feel the abdomen if there's any abnormality. So, and if the patient is sick, a CBC will take just like 1 hour to come back. So the patient even can wait, go for lunch and come back. These things are simple. If you send him for a CT scan and he's lost, it's a big problem. That's what I wanted to say.
Okay. شكرا دكتور علا. Yes, yeah, I forgot to mention this. Always in any neoplasm, suspected neoplasm in any child, always request a peripheral blood film to look for any abnormality, any blast. It's very important, and you should also mention it في الexam. Okay, إبراهيم منصور.
الو السلام عليكم دكتور.
وعليكم السلام. هلا. So this patient, he's 70 years old, complaining of this mass on and off, although it's usually there, but it's on and off with pain. So what are the questions that you want to ask?
Yes. This is an external photo. I'll start with the description of this photo. This is an external photo showing focusing on the left eye, showing medial canthal focal swelling with. I think the eye is quiet, and the rest of the eyelids is normal. I'm not sure about the changes in the upper cheek. Is it age related? Anyways, I would ask about the medical systemic medical review of the patient. Is free or not? And this lesion started when?
So the past 6 months, progressive, on and off swelling like this, but the swelling is always there. Sometimes it gets inflamed.
Okay. Any history of tearing, chronic?
There's tearing.
History of any eye complaint, I mean regarding the vision or the motility or the diplopia, sorry?
No.
Any, I mean, malignancy before?
No history of malignancy. So upon examination, there is a hard mass, or it's very hard to palpate this area. So what?
Tender?
Yes, tender. So what's the what else you will examine for?
I might do. For me, it could be as long as it's recurrent. It could be a cystitis.
Okay, so dacryocystitis.
Yes.
What are the suspicious signs of atypical dacryocystitis or masquerade? What are the signs?
Yes. I mean, blood with tearing.
Okay.
Plus the destruction of the lower eyelid. Ulceration, loss of eyelashes around that area.
So he had palpable lymph node. Very important to mention.
And
and the palpable mass, you can palpate to this area. There is a swelling. Well, what will you do? You will go right ahead for DCR?
No, I prefer to do imaging still.
What about regurgitation?
And yeah, I will test for regurgitation to see if there is any rigor and what the nature of the regurg.
Right. So this is the imaging, just briefly.
Yes, this is coronal CT scan showing hypodense, homogeneous, I think heterogeneous mass in the left orbit nasally with the bony destruction of the nose and ethmoid one.
Okay.
Also, the maxillary sign is involved.
Yes, ethmoid maxillary. So again, what are the suspicious symptoms and signs?
In the imaging or the symptoms, or in general? All.
In general.
Yeah. The palpable lymph nodes.
So by history first, you mentioned something. Bloody tears.
Yeah, bloody tears.
History of malignancy.
History of malignancy. Aging also can give you a hint, although dacryoadenitis is common among elderly.
So bloody tears, history of malignancy, examination. You mentioned lymphadenopathy. What else?
The site of this lesion also, and the changes around that lesion. I mean, there is any destruction or ulceration.
Okay. So there is always, when it's extending, always palpate carefully. When there is extension above medial canthal tendon, this is a suspicious sign. If you check the literature, you will see that there are some incidental finding. They diagnosed the patient to have nasolacrimal duct obstruction, and they found to have a mass, while they thought it was a routine DCR. So let's say that you are doing the DCR and you found a suspicious mass. What will you do on table?
I might take a biopsy and send it.
No, not might. You will take a biopsy. Okay.
Yeah.
And will you proceed for and do the surgery?
If I can hold mass, I would do it. But you mean regarding the DCR, I would complete it or not? I might wait for the biopsy if I can. If I send
So you took the biopsy and you took an adequate one on table. So what will be the next step? Will you proceed to continue DCR?
No.
Why?
Because if this is a malignancy, I might separate this.
Exactly. So you shouldn't do a bone window at all.
Yeah.
Although this is rare, but it's a good practice when you do DCR, just to check the preorbital and the adjacent lacrimal sac if there is any suspicious sign. Okay, so bloody tears, history of malignancy, lymphadenopathy, palpable mass above the medial canthal tendon, and no regurg. Dr. Halan, I noticed, although this is a symptom of malignancy, but sometimes I find that mucocele are not compressible. So it's not that accurate to say no regurg equal suspicious sign. What do you think?
I agree with you, because having a mass with pain, especially if they have pain, it's more likely that it is related to the lacrimal. Because in dacocystitis, initially you have edema in the upper system, and it will block the upper system. So they will have what you see as a cyst or like a mass, and even though it's not inflamed at that time, maybe not red, but it could be painful, starting to become inflamed, because you're having a reservoir of infection, and at the same time it just block the upper side and cause that problem. But if it is a long-standing history and they have a chronic, it became chronic dacocystitis, no inflammation, also you can have a mass and regurgitation negative, and it doesn't not compressible. Also, they don't compress, and it is in a reservoir up with blockage of the upper and lower system.
I see.
But I mean, it's maybe they mean it in a sense that you don't have the classical sides. It is a suspicious that you have no regurgitation, rather than it is a like something you would alert you to a malignancy. It's just like it's something which adds an information.
I see. شكرا دكتورة. طيب. So there are still a couple of slides, but I think we're doing well. So let's see. Yeah, Abdurrahman Khan, if you can unmute.
السلام عليكم دكتور.
Hello, alaikum salam, حياك الله. So this patient, 40 years old, and he noticed asymmetry. If you can just tell me how will you approach?
So I will start with the history. I want to ask, since when they noticed the
Can you
asymmetry?
describe first before?
Yeah, so this external picture showing both eyes of this patient. What I can see is The right upper lid seems to be, there is asymmetry between both the lids.
Okay. So always check the lower lid if there is more scleral show, if there is any injection, any displacement. So what do you think? Is there any asymmetry in the scleral show?
Yes, it looks like in the right eye, there's more scleral show compared to the left eye.
Okay.
Yeah.
So I think we covered in this lecture and the previous one the history and the parameters of the examination. So what will you do?
So we can do imaging, proceed with imaging.
Okay. So can you describe?
Okay, so I'll start from the left picture. This is a axial MRI T2 showing a mass in the right orbit causing proptosis of the globe.
What's the location?
It looks mainly in the nasal part of the orbit. Maybe
Is it inside the muscle cone or outside the muscle
cone? I think it's inside.
So I'm trying to just lead you, and the previous slides. I'm trying to lead you because these are the buzzwords that you need to mention in the oral exam. So yeah, it's intraconal. You can see the recti muscle. Okay. So we discussed this when you rotated. So what's the differential diagnosis of a well-defined intraconal tumor?
We can think of like benign neoplasms like cavernous hemangioma,
okay.
like optic sheath meningioma.
Let's go back to the picture. So this cut is a little bit inferior. You cannot see the optic nerve. So cavernous hemangioma is one. So well circumscribed mass.
Yes.
What else?
It could be maybe like related to again maybe some neural tumor like schwannoma or optic nerve glioma.
Okay, schwannoma, cavernous hemangioma. What else? We discussed this, wala?
Maybe some lymphatic tumor, or maybe fat related to the fat.
Okay, so this is from Will's eye manual. It's frequently asked question in the oral exam. So fibrous histiocytoma, another name of now it's in one category, is the solitary fibrous tumor. Neuromoma is another name of schwannoma. So these are the main differential. The most common is, of course, cavernous hemangioma. The second most common so far that I saw is schwannoma, and usually it's associated with pain and headache. Okay, excellent. Now we have two more cases. So let's see. في شو اسمه نواف من قبل.
هلا دكتور. السلام عليكم.
هلا حياك. هلا وعليكم السلام. طيب, can you just describe and tell me the differential diagnosis?
طيب, I'm seeing an external photo of a child showing a bluish swelling in the medial aspect above the medial canthal tendon of the left eye.
Mm-hmm.
It's causing some ptosis, the upper eyelid, mechanical ptosis.
Mm-hmm.
I want to know more of the history. Is it present since birth or no?
So they noticed it at 4 months of age.
Okay.
And became larger the past.
Larger.
Yeah.
Is he a boy or a girl?
Why would this make any difference?
No, if I'm thinking of capillary hemangioma, girls are more affected than boys.
Okay, other than that. On examination, what will you look for?
I should look for cutaneous lesions.
Okay.
Strawberry nevi. I would look if there's a deeper seeding, like preseptal seeding.
Ocular exam, why?
I would check the fornices.
Okay. What about the ocular exam? What will you examine?
I'll examine if it's covering visual axis or no.
Okay.
Check for amblyopia. I would check for ABD.
Okay, what else?
I'll palpate the lesion. I'll check for if there's any pulsatile waves in the lesion. I'll ask about the variation, day variation of the lesion. Does it get larger with the specific activities of the child or no?
You mean Valsalva?
Yeah, or if the child is sucking milk or something, it will get larger.
Okay, so always an examination, check the blanching and compressibility of the mass, and if there is any Valsalva. Still, you need to mention, very importantly, the fundus exam and cyclorefraction, just to rule out any astigmatism, and to check the optic nerve. Okay, so what's the most likely diagnosis, or give me a differential and the most likely diagnosis?
Most likely diagnosis is capillary hemangioma.
Okay. Other differential?
Cavernous hemangioma could present sometimes like this.
Cavernous in a child?
Yes.
You shouldn't accompany these two words, cavernous and a child.
Yes.
It's very rare.
Since it's above the medial canthal tendon.
Sorry?
Encephalocele, since it's above the medial.
This discoloration, you would focus on vascular lesion. So just to mention, port wine stain, although it's much more extensive, darker, and does not blanch. Lymphangioma usually older and associated with or exacerbated with upper respiratory tract infection and eyelid or orbital varix, however, would present at an older age. So indication of treatment. What are the indication of treatment?
If it is causing amblyogenic anisometropia.
So what's the most likely refractive error you will see?
Astigmatism with them.
Okay, so if there is any astigmatism, what else?
If there is accompanying strabismus.
Okay, usually strabismus is what will happen secondary to deprivation amblyopia. So deprivation amblyopia will happen from as a result of what?
Covering the visual axis. Ptosis covering the visual axis.
Okay. What about other finding or other indications?
If the optic nerve is compressed, signs of optic nerve compression on imaging.
Okay. Other than ocular, any indication other than ocular? Okay, so dermatological, you mentioned the ocular very nicely. Dermatological, if there is an extensive one causing, if it's elevated, eventually they undergo hypertrophy and ulceration. So it's very important to check that it will not happen eventually, because it causes a lot of shortening of the anterior lamella. A systemic indication, we'll go through that now. Management, So there is a natural course. There is no ocular or dermatological or systemic indications. You can observe it because it undergoes spontaneous regression. And always important to check if any deprivation or anisotropia with frequent cycloplegic refraction, and to see if the patient needs glasses or patching. Okay, so can you tell me about the different treatment modalities and drugs available?
So we can use beta blockers, doctor, like oral propranolol.
Okay, so if you decide to give oral beta blocker, what's the precautions or the things that you will do before initiating? Will you initiate it by yourself right away?
You need a pediatrician if the child is asthmatic or has any cardiac symptoms. You cannot initiate beta blockers.
Yeah, so always involve a pediatric, and usually you need to admit the child for while initiating the medication, and to check for any bradycardia, hypoglycemia. Okay, what else other than oral beta blocker?
We have intralesional triamcinolone.
Okay, and what are the complications of intralesional?
Usually, because skin changes, depigmentation, and necrosis, it could cause fat atrophy. It has a systemic effect on the adrenal glands.
And it's very important to mention retrograde retinal artery occlusion.
Yes.
Okay, other the medications?
There are some steroid-sparing agents, but I don't recall the name.
So, okay, systemic steroid, it's mentioned, but so far my experiences with oral propranolol, alhamdulillah, it's going nicely. I didn't need to inject with corticosteroid, or topical timolol is also mentioned in the literature. And also surgical excision, so far I haven't done one so far, because propranolol, alhamdulillah, it's very successful. So what are the associated syndromes or conditions? This is also a very important oral exam. You can see that I'm stressing on the frequently asked question in the oral exam, because this is the point of this talk, as well as being a very safe physician. So what are the associated syndromes or conditions?
We have Dr. the Kazabach-Merit syndrome, which is a consumptive platelopathy. The platelets are sequestered, and the patient results in hypercoagulable state.
Hypercoagulable?
No, hypo.
Yeah, so because of the sequestration, they have thrombocytopenia. Usually they have other, as you mentioned, to examine other the whole body for other similar masses. Okay, other than Kazbach-Merit.
It could be, doctor, some part of the face syndrome.
So what is face syndrome?
Face, the P stands for posterior fossa malformation, the H for hemangiomas, the A for arterial abnormality, the C for cardiac problems, and E for eye abnormalities. Some people add the S for sternal cleft.
Okay, what other syndrome or condition? Okay. So Maffucci syndrome is also associated with it. So the reason that oral beta blocker became very successful treatment was it was an incidental finding. There was a patient with very large hemangioma with high output cardiac failure, and they started beta blocker for the child, and they noticed shrinkage of the hemangiomas. It's very interesting. Sometimes you can discover treatment like this. So, okay, now we need another senior, Dr. Msha'el Khayal. So this is the last case. The first part was much more extensive. This was the second part, alhamdulillah. I think it's much easier and smooth. طيب. So this
أيوة.
this is
السلام عليكم أستاذ.
hello, عليكم السلام. حياك الله. 20 years old female with the sudden onset of this proptosis.
20, okay. So I would start with the history. I'll ask about the onset.
Sudden.
The course, sudden. Since when?
So for a couple of days.
Okay, is it associated with any pain, diplopia, decrease in vision?
There is pain and diplopia.
Okay, any history of previous surgery, trauma?
No.
Any history of medical disease?
No, but she had a flu recently.
Okay. Is there any history of similar attacks in the past?
Yes.
Okay. So I'll start with examination.
So let's proceed to the imaging. Can you describe?
Okay. So this is an MRI T2 of the orbit, showing a heterogeneous multiple lesions with fluid level.
Excellent. So cystic lesions with this fluid level, as you mentioned. Okay. So is this what type of cyst is this? Is it micro or macro cystic? Like this one and this one.
Sorry, Dr. إيش ما سمعت.
So is this a microcystic or macrocystic?
It is macro because it's more than 2 centimeters in size.
Okay, excellent. So what's the most likely diagnosis?
Most likely diagnosis is lymphangioma in this case.
Okay, what's the new name of lymphangioma? What's the new term of lymphangioma?
Lymphovascular malformations.
Okay, so it's lymphatocavenous. So this patient, let's say that she has completely normal exam when it comes to that there is no dry exposure keratopathy, no optic neuropathy. What will you do?
No signs of, yeah. We'll observe the patient closely.
Okay.
Yeah, for the hemorrhage to be absorbed.
Okay, and if you want to treat these macrocystic, what treatment modalities that you can offer to the patient?
Sclerosing agents, such as bleomycin.
Okay, what other sclerosing agents, you know?
Other sclerosing agents?
Yes.
So I cannot recall.
Okay, so sometimes I give steroid just to have a better, faster recovery, and it helps in the pain. So sclerotherapy is very effective in macrocystic. It's very important. as you mentioned, more than 2 centimeters, and it doesn't work that much in microcystic because it's difficult to inject inside these malformations. So example, as you said, bleomycin, OKN32 is another one. Doxycycline also is mentioned. But here, as far as I know, in our country, the most commonly used is bleomycin. OKN32, the Kekish used to inject it long time ago. So what about medical treatment? Any medical treatment?
Medical treatment, steroids.
Okay, other than that?
And acute state.
So sildenafil or Viagra is also mentioned. Still, it's under
Sildenafil.
Sildenafil, yeah, but still, it's there are a couple of trials ongoing. However, upon discontinuation of sildenafil, they noticed some relapse. I think it's going to be published this year. So still, so far, the most promising or the best treatment for macrocystic is sclerosing therapy. So it's very important to know that there is difference between tumors and malformation. So this classification maybe will be different than the one you see in different articles. So, but generally speaking, lymphangioma or lymphatocavernosus malformation is a low flow. Cavernous hemangioma or cavernous venous malformation is low flow. That's why it can be managed by us as an oculoplastic or oculoplastician. However, the mixed and high flow, you need to involve a neuroradiologist and intervention radiologist. So always, whenever you have a malformation, you need to know about the flow. Okay, just going to the first slide, it's very important, one of the first slides, about the onset, okay? So this patient, so always traumatic and hemorrhagic is, it happens very fast. Okay, so thank you very much. This is the last slide. If there is any question, Faisal?
None yet.
Because I was seeing in the chat, there was a lot of, like 166.
Most of them were answers.
Okay, great. So, any questions? If we can check the chat, you can ask now, please. Yes, sirolimus is one of the treatment. Excellent. Unfortunately, I cannot check the while presenting. Okay. Excellent. طيب, any questions?
الله يعطيك العافية دكتور على المحاضرة الرائعة. تسلم.
طيب, يعطيكم العافية وبالتوفيق، وإذا احتجتوا أي شيء مستقبلا you can contact me. شكرا دكتورة هالة، الله يعطيك العافية، شرفتينا بحضورك.
Thank you very much. Thank you.
فرصة سعيدة. يلا يعطيكم العافية وبالتوفيق جميعا. فمان الله، حافظكم الله.